Hi, my name is Abdul. I'm a third-year neurosurgery resident at the University of Maryland. I want to talk about the bilateral MR-guided focused ultrasound thalamotomy of the central lateral nucleus for neuropathic pain. These are our early results from our phase 1 trial that we are all involved with here. I have no disclosures. So I want to talk about neuropathic pain, modes of management, and I want to talk about the central lateral nucleus and why thalamotomy is sometimes approached. Then I'll talk about the trial design and safety and pain outcomes. Neuropathic pain occurs after a lesion or disease of the somatosensory nervous system. It affects many individuals. Chronic pain itself accounts for $560 billion in annual direct and indirect costs. It leads to a loss of quality of life. There are many first-line medications. Many patients do not find relief. So in some of these patients, surgery or interventions are pursued. One surgical target for this is the central lateral nucleus of the thalamus, previously called the medial thalamus. It is a component of the theoretical framework called thalamocortical dysrhythmia, which is proposed to underlie this phenomenon. It transfers nociceptive information from pain tracts to secondary cortices and the anterior cingulate and prefrontal cortices, which can result in behavioral changes. Jean Monod is really a leader in this field and an inspiration to us. He's described his case series of performing central lateral thalamotomy using stereotactic radiofrequency ablation, where he targets the CL nucleus 2 millimeters posterior to the posterior commissure and 6 millimeters lateral to the thalamoventricular border. He treated patients both with bilateral and unilateral CLT, and on his follow-up he found that 53% experienced greater than 50% relief on the visual analog pain scale. He found better outcomes in intermittent pain in patients with peripheral etiologies. He published his results using MR-guided focused ultrasound to perform a central lateral thalamotomy, 5 unilateral and 6 bilateral. He had 8 patients with 1 year post-procedure follow-up. He found that 40% had an improvement in the visual analog pain score at 1 year. 5 patients took no medications. You can see that he performed bilateral treatment on this T2-weighted image on the right side. So for us, in our trial, our intent is to enroll 20 patients to perform bilateral central lateral thalamotomy. The reason to perform bilateral is to address this thalamocortical dysrhythmia etiology of this phenomenon. This is a single-arm, non-randomized, unblinded study. First, we want to evaluate its safety and feasibility, particularly in treating medication-refractory neuropathic pain. We also want to evaluate efficacy of this intervention using pain scales like the Brief Pain Inventory and Pain Disability Index. We will include patients with severe neuropathic pain from radiculopathy or radicular injury, spinal cord injury, or phantom limb pain. We want to include patients 21 to 75. They have to have an eligible skull density ratio, pain that's confirmed by a neurologist for more than 6 months and failing standard of care. We want to include patients that have prior deep brain stimulation or CNS disease, and of course, they have to be able to tolerate the procedure. So we have treated 5 patients. You can see their age and skull density ratios here. We had a patient with phantom limb pain, one with failed back syndrome, another one that had a crush injury, a brachial plexus avulsion injury, and one with a spinal cord injury. So many different etiologies, and they had failed prior interventions on top of failing medical management. So you can see our treatment parameters here. Patients were in the scanner for about 4 hours. About 55 degrees Celsius maximum average temperature was achieved. One patient could not tolerate being in the MRI, so only underwent unilateral treatment. In terms of safety, in the 4 patients followed for a year, there were no serious adverse events. They only had headache or pin site tenderness from the stereotactic frame, all of which resolved within 1 week. In terms of brief pain inventory scores, we found a 57% reduction in 4 patients followed for a year. And pain disability index, we found a 48% reduction in that metric after 1 year. This is a patient treated with unilateral CLT. You can see the lesion at post day 1 from procedure and at 1 year from procedure. And this is a patient treated bilaterally. And again, you can see the remaining lesions 1 year out from procedure. So 2 patients had no change in their medication. 1 patient reduced their tramadol, bupropion, and hydrocodone. 1 decreased their morphine sulfate, and another decreased their gabapentin. We conclude that this treatment is both feasible and generally safe, and the patients that we had selected for did tend to benefit from this procedure. A future study is needed with a control arm. We also found that a few of these patients reduced their pain medication intake, which is an important metric to consider. Some lessons we learned from this trial are that radicular pain is more responsive to this treatment, so patient selection is vital. Pain medication intake is also very difficult to track. These are my references. Thank you so much to the Focus Ultrasound Foundation for this opportunity.